Good afternoon, everyone. On behalf of the faculty, postgraduates, and the staff of the upgraded Department of Pathology, Andhra Medical College, I'm Dr. Satyashri, Associate Professor, extending a warm welcome to all of you for this fifth oration of P.V. Jagannadha Rao Memorial. And it is being delivered by Dr. Sudha S. Murthy, MD, DNP, former Director, Dedar Cancer Genetics, Nasik, India. And she is one of our proud alumni. ఏ దేశం ఎగినా ఎంత ఎత్తు ఎదిగినా మన తల్లి ఆంధ్ర వైద్య కళాశాల మనం మరవకూడదు. So wherever we are and whichever position we are in, we should never forget our alma mater, Andhra Medical College. So this is a message which is given to us by the family members of Dr. P.V. Jagannatha Rao, his son and daughter-in-law, Dr. Ravindranath Sharma and Dr. Seshu Sharma. They helped in the renovation of the Pathology Department, the lecture gallery, the museum, the practical hall, by contributing a huge amount of 1.5 crores. And this oration is being sponsored by their grandchildren, Indira, Gopal, and Sriram, who are the children of Ravi Sharma Garu and Seshu Sharma Garu, in the honor of their grandfather, Dr. P.V. Jagannatha Rao. The Department of Pathology immensely thank you for your magnanimity. Be it hunger for knowledge or hunger for food, the family who is settled abroad in Atlanta are ready to help Andhra Medical College and King George Hospital. So they are voluntarily donated for giving afternoon lunch through Subhojanam for a year for the in attendance of the KGH inpatients. So as all of us are facing, time is a constraint in this modern era. But if we see that both Ravi Sharma Garu and Seshu Sharma Garu are actively contributing for the coming centenary celebrations, they are very active on the WhatsApp. They are taking all the messages, they are compiling all the data, and every day we see they are coming up with some profile. So we have to immensely thank them for giving us this cooperation from abroad. So now I invite our Professor Dr. G. Parvati to come on to the dais. So I request our Professor and HOD, Dr. C.V. Lakshmi ma'am, to come and occupy the chair. So both our professors, Dr. Lakshmi and Dr. Parvati, are doing immense job to keep always Saraswati in our department. So in history, we read about Ashoka the Great. But today in practicality, we are seeing our superintendent, sir, Dr. P. Ashok Kumar Garu, who proved that come what may, nothing can stop him from serving his alma mater. Sir, please come and take the chair. We read about gods giving so many gifts, kings giving so many gifts. But today in Andhra Medical College, we have our principal ever smiling and ready to give us anything we ask for our department. Sir, Dr. Pudipeddi Venkata, please come and take the chair.
Thank you, Dr. Satyashri. Good afternoon, one and all. It's my privilege to read out the biodata and introduce Dr. P.V. Jagannatha Rao, who has contributed a huge amount to our pathology department. Dr. Pudipeddi Venkata Jagannatha Rao was a student of Andhra Medical College, who later served as a faculty of Medical College in Anatomy and Pathology. He was in He was in government service before returning to obtain his MD degree in pathology. During his tenure in the Department of Pathology at Andhra Medical College, he was the director of the clinical laboratory in charge of the morgue and diligently worked in preserving and cataloguing the specimens of the museum. He later worked at Gandhi Medical College, Hyderabad from 1968 to 69, and as a professor and chairman of the Department of Pathology, Kakatiya Medical College from 1969 to 74. After his retirement from Kakatiya, he worked at Dhanbad Medical College, Bihar, now known as Jharkhand. He retired in 1980. He lived in the USA with his eldest son's family and passed away in 2004 at the age of 85. He was a simple man, honest to the core, a scholar, and had an incredible curiosity and thirst for knowledge. Renovation of the Department of Pathology block was undertaken on his behalf by the family by his eldest son and daughter-in-law, Dr. Ravi Sharma Garu and Dr. Seshu Sharma, who belonged to the classes of 1966 and 69 of Andhra Medical College. And they dedicated the lecture gallery to the Department of Pathology on April 10, 2019. With this, I now request our principal sir to say a few words. Lighting of the lamp, sir, first.
I was in pathology and microbiology during 66, 67, and I am very fortunate to have our Jagannadha Rao as our teacher, who used to teach us neoplasia. So probably I am the only person who is a direct student here. I am nearly 76 years old. Naturally, I am the remaining student here. Thank you.
I now request our principal sir to say a few words.
Good afternoon, everybody. Dignitaries of the dais, Dr. Sudhamurthy, Superintendent Dr. Ashok, Dr. C.V. Lakshmi, Dr. Parvati, Professor of Pathology, and other faculty, senior professors, and students. It's indeed a great honor during the centenary of Andhra Medical College. We are having the fifth oration of Professor Jagannadha Rao, who has worked here for a few years, as you saw from the biodata. But we have the oration is named after him by his grandchildren, and his son, Dr. Ravi Sharma, and daughter-in-law Sesh Sharma, who are the distinguished alumni of our college, have done quite a lot to the college, and they're still doing, as already enumerated, they have renovated the whole pathology department block by nearly 1.5 crores. Probably that is the biggest donation by a single family to Andhra Medical College, as far as I remember. And they also continued, not only renovating, they have continued, they're quite benevolent. And in the centenary year, last 1 year, they are supporting the Subodhana for the attendance of King George Hospital. Even they also have contributed quite significantly for the upcoming centenary alumni building. And not only that, they are both Ravi Sharma and Seshi Sharma are working very hard to bring out the coffee table book and history of Andhra Medical College, which actually has given 10 prologues. Some of the contents of the prologue, even I was not aware, even though I'm a student of this college. So they are quite every day they're giving helping us in conducting the centenary. Not only that, recently when some old students came to our men's hostel, they found the mess was having some issues, the ceiling. So again, the same people, around 5 alumni have contributed 10 lakhs for renovation of the mess, both the ceiling and out of which 2 lakhs was given by again Dr. Ravi Sharma. So they have done quite a lot, and it's our honor to remember them during this occasion. And coming to another alumni of prestige for Andhra Medical College, Dr. Sudhamurthy, will be speaking on precision and oncopathology. Just last week we had one lecture from one of our alumni from Ankara, who spoke on precision in clinical oncology. So now we are continuing with the similar subject, but that's what we see in the day-to-day. And also to remember her brother-in-law is our batchmate, Dr. Rao is professor of neurosurgery in Bihar. So it's good that one of our good alumni who is coming and giving a donation gives us a great pleasure as principal for the in the centenary of Andhra Medical College. Thank you.
Thank you very much, sir. I now request our Superintendent Achal Kumar sir to say a few words.
Good afternoon. The dignitaries on the dais, Principal Dr. Pudipeddi, Dr. Lakshmi, Dr. Parvati. So naturally Saraswati will be there. So we have a series of lectures which are very interesting. And what I feel today's lecture is even more interesting. So I congratulate Sudha, and also let us enjoy this. Thank you very much.
Association of Molecular Pathology, IAPM, IAP International Division, Molecular Pathology Association of India, Equitable Healthcare Access Consortium, to name a few. With this brief introduction, I am honored to invite Dr. Sudha S. Murthy for the felicitation.
Medical College, Visakhapatnam, Centenary year 2023, affiliated Dr. YSR University of Hyderabad, this certificate has been awarded to the highest Sudhamurthy MBBS for giving Dr. P.V. Jagannatha Rao Memorial Oration at Andhra Medical College, Visakhapatnam. Finally, the principal has been done. Now request to
Good afternoon, respected principal sir, Dr. Bujraji Garu, Dr. Ashok Kumar sir, Ramalakshmi madam, Bhagilakshmi madam, Dr. C.V. Lakshmi, Satyashri, and Dr. Parvati, and all the students and faculty here. I am delighted to come back to AMC. Every time I come back to AMC, it gives a sense of pride because college is something which has given us our identity, our birth, and I think all of us should really feel proud as alums of Andhra Medical College and do whatever in whatever way we can. And it's really an honor. And I thank Principal Sir and Dr. C.V. Lakshmi for having invited me here. It's indeed a privilege. Now, having been in the oncopathology space for last 24 years, this is just a snippet of what I can share about my journey. It is not to tell that, I have accomplished so much. But for the youngsters, yes, this is a good opportunity. You are here at the right time, and possibly if I can inspire at least 4 or 5 students in this gathering, my job is done. And that's what I believe whenever I speak about oncopathology. So we know that precision cancer medicine, as Sir had already alluded to, it has now taken a paradigm shift. You might be thinking that I am in a government hospital. When would I see that? Please don't be complacent. It is already there in our country, and it will be soon fitting with the policies of the government. It will be available at your center as well. So it's very important as youngsters, as postgraduates, that you understand that this very complex science. If you remember, COVID has taught us what is RT-PCR.
what is molecular. No one knew about what was RT-PCR. So precision oncology or diagnostic precision cancer medicine is also going through that change, and pathologists contribute significantly, and that's what I'm going to allude to in this short session. Now, traditionally, I'm a histopathologist, so we cater to surgeons who provide us the tissue to give the diagnosis, grade the tumor, or stage the tumor. And things have moved. Now, it's not just the surgeons who are our clients or customers. If you say, today it's called healthcare industry, though all of us in academic medicine, we believe it's not an industry, but nevertheless, it's very important to know whom are you catering to. So all our clinicians are very important for us, and of course, the patients. So it's not the surgeon now you need to address. Now, medical oncologist is a very good friend of yours, and that's what precision cancer medicine will teach you, that you have to work in teams along with all the clinicians. We are answerable. We have to be on their boards. We have to communicate at the same level along with the oncologists and other specialists that we are dealing with. Now, we have known that the traditional method of treating cancers has been that you have the standard of care, whether it's NCCN guidelines, ASCO guidelines. So you have a standard for this tumor, you do a chemotherapy, you do radiotherapy, you do there's a surgery. But now with the advent of precision medicine, things have changed. How has it changed? One size does not fit all. Each patient is different. We have to look at the genetic framework of that particular patient in the light of your morphology and also the clinical findings. And this is what the precision oncology has made a difference about. Now, because we do not have too many cases from our country, probably there is not a very sensitized cohort, so to say. But with the kind of molecular workup that is being done, at least as of now in the major cities, soon we'll have our own data, which will tell us which works for us in our ethnic cohort and which does not. And therefore, it's pertinent for all of us to know what is precision cancer medicine. It's not a medical oncologist or surgical oncologist job. It is us pathologists who need to do the test, which should convince them that yes, I am getting a good data from this patient and I shall treat accordingly. So precision oncology is nothing but instituting the right treatment to the right patient at the right time. So as I told you, it involves a lot of molecular. You don't need to really bother about. You might say, I have no inkling to what is the molecular profiling. I don't know the basics of molecular except what Robin's pathology or my anatomy has taught me. But it is important in every specialty now. Molecular has percolated. Whether you call it neuro-oncology, whether you call it surgical oncology, everywhere there is molecular. Hemato-oncology. Not only cancers, even others. In Alzheimer's, we have molecular. In nephrology, we have molecular. So everywhere, so it's important as pathologists for us to understand that precision oncology is here to know. And so the outline of my talk would be about the evolution of cancer diagnostics, role of histopathologists in the new era, the basics of molecular testing, next generation sequencing of solid tumors. I'm not going to touch upon hematopathology, that is not my specialty. And then a little about liquid biopsies, which are now becoming complementary tools along with the solid tumor sequencing, biobanks, and novel tools in cancer diagnosis and research, which I have had the privilege to be part of at Data Cancer Genetics. So pathology, as we know, is the bridge between the bedside and the bedside, and pathologist is the bridge between the oncologist and basic scientist. Now, it has moved, the evolution of cancer diagnostics has been that we have moved from standard histopathology, cytopathology, hematology, clinical pathology to FISH, flow cytometry, which all of us seniors would be conversant with. Of course, immunohistochemistry is a part and parcel of our reporting. RT-PCR, capillary electrophoresis, and now next-gen sequencing, including liquid biopsy, microarray, and now single-cell analysis. They're looking at single-cell sequencing that you are getting the genomics. Genomics is the DNA data, transcriptomics, which is the RNA data, all put together, you're talking about. So what are biomarkers? Biomarkers in the context of oncology, these are either DNA, proteins, RNA, or even your histologic findings, which help you ascertain whether there is tumor or there is a lurking tumor if it's a treated case. So that's what is biomarker in simple terms. Biomarkers can either be predictive,
That means they predict the disease and or prognostic. So for example, for the predictive, you would have the HER2s and the ERs and KRAS, EGFR, etc. Whereas prognostication is only to tell you what is the outcome of the disease. Now, to give you a poster, the example of a poster child, that is a lung cancer. Today, even at a tertiary, at a primary care center level, you need to take care of your block. It is very important, even if you are outsourcing your molecular workup, because every lung cancer has to have a molecular profile. You cannot do away with the molecular profiling. An oncologist won't touch the patient without doing an EGFR testing. So as pathologists, it's our duty to ensure that the block that we are providing for the molecular profiling is optimal. It does not matter where you are, whether you're in a government hospital, whether you're at a private lab, whether you're in a tertiary care center. It's the pathologist's responsibility to ensure that we give a proper block. And it's very important that this block or the tissue that you're cutting from this section from the block is treated appropriately. Earlier, we used to do, if it comes to us, we would do lots of IHCs. The tissue would be depleted. You cut so many sections, the patient is hardly left with any tissue. And when the oncologist asks for a block, you don't have any tissue left. So as pathologists, we have to be very sure. If it's a straightforward adeno or squamous carcinoma, don't do any more IHCs. Just preserve the block for a molecular testing. Similarly, the processing of the block, it is very important today. You cannot just leave the block, the tissue in formalin for hours together. Why is it so important? Because now we know that the lung cancers are divided on the basis of molecular profiling. So all these, I won't run you through these different genes. It is very boring if you really want to go through it. But please be aware and conversant of all these markers so that at least you don't find it, very annoying or new when someone asks you. As a pathologist, you would be expected to understand all these things. Why is it important to, what is heterogeneity? Heterogeneity means that the tumor profile, whether it's a phenotype or the genotype, is different from one site to the next site. So it is not the same always. And therefore, if you're sampling a small tissue, there is every chance that you are not really getting the total profile. And that's how liquid biopsy has come into the picture. We'll look at that later. Now, as a pathologist, what would I do? I would macro dissect my tumor. So what is it? I'll mark the tumor. For the understanding of the younger ones, it is, you have a section. Nowadays, you get a small biopsy. You don't get a huge resected specimen of lung. You would get a small tissue in which you will have to mark that tissue and give it to the molecular biologist to do a molecular profile. Without a pathologist, they will not be able to do a successful molecular profile. So please understand that it is our responsibility to identify the tumor part. People are saying AI will come and replace it. It will not happen. It is not going to happen. Now, if you don't do macro dissection, there are other advanced technologies which no one is doing in India, which is called laser capture microdissection, which is, at least you should know these names. And then optimal utilization of tissue. How would you do that? You would, there are different protocols that each lab uses, but here we would do probably, we divide it into 2 blocks so that even if it's depleted in one, you are identifying 1 block for the molecular tissue. You would also do tissue-based customization. Now, why is it important to know that fixation has to be seen? You might say it's the histotechnician's job. Sorry. So that is also again our job. The histotechnician would obviously not listen to it because unless we are overseeing that, they would not really get into the picture. Again, you will have to fight with your management for a good paraffin wax. That is also pathologist's responsibility. So if you're getting sub-quality, now management would say, I'll get the L1 wax. Because tomorrow we are responsible for the quality of the molecular block. So the pathologist has to play a great leadership role to converse with the management to get the best quality for this our department. I'll not go into this. Now, we have moved from single gene. Earlier, it was like, you are doing EGFR by PCR and ALK by IHC, ROS1 by FISH and things like that. Now we have moved to next-gen sequencing where all of these are done in one go. You have nothing, no difference. So you're saving on tissue you are saving on resources. So why choose party packages over a la carte? This is the reason why. One, economics, very important for the patient. You have to think in patient's perspective. It's all patients centric today. So I would obviously, if I have the facility, I would go for an AGS rather than doing an IHC bar for cross tissue gets depleted, and it doesn't make sense. But even if you outsource it, it's important that you have a knowledge about that. So when your doctor is asking, we are the ones who will be actually interpreting it to our oncologist. So by NGS, multiple targets in multiple genes in multiple patients simultaneously you're doing instead of going one by one sequentially. Now, is it possible always to do a comprehensive molecular profiling? Sorry. So it's not, especially in our country, affordability is a big issue. Availability of representative tumor also may be a challenge, and integrity of the tissue, especially in centers where you do not have proper facilities. This is just an example for you to show how molecular has penetrated into other areas as well. Now, this is the classification of endometrial cancer has totally changed because there's a diverse group. I'm not talking about the classification here, but this was a 41-year-old lady who had presented to the local gynecologist with menorrhagia, and ultrasound showed a tubo-ovarian mass, which was about 2 centimeters, and the HPE diagnosis was endometrioid carcinoma. She was referred to a cancer center, and after taking proper history, they realized that there is a strong family history in this patient. The patient's mother had ovarian cancer as well, and her pinny or aunt had endometrial cancer, and her thank you. Thank you. And uncles also had cancer. So this patient underwent sequencing and they found that it is MSH2. Now a pathologist only had identified. Pathologist said this is MSH2 loss, and therefore probably this is a case of Lynch syndrome, which is a genetic disorder that, and these patients need kind of cascade testing for family members to identify whether these the other family members also harbor the gene and prevent it if possible in these patients. So that's how again here the pathologist puts everything. So it's like a jigsaw puzzle. She's putting her pathology knowledge, her immunohistochemistry, her NGS report, and making it sensible to the oncologist to act upon. Otherwise, without our inputs, they would not be able to institute some management to the patient. So that is again how a pathologist would. This is another one, as we all know, nowadays Ewing sarcoma or Ewing sarcoma, if you so call it. It's very important. You have to have molecular evaluation to diagnose this condition. So this was one series of our cases at Basavatarakam wherein we had EWSR. Now at that time it was acceptable that you're just doing an EWSR, establishing that EWSR or it's an Ewing sarcoma. But today we know that EWSR can be seen in other tumors as well. And that is again where precision oncology has come into the picture. Now, why did this liquid biopsy come into the picture? Clinicians here would know that when you get a lung cancer or any other cancer for that matter, there are several times where it's only the metastasis in the bone which is the presentation. You don't have the primary tumor. So what would you do with taking a tissue? Because you cannot do molecular profiling on a bone tissue. We know decalcification harms the tissue. So what would you do? And these are the cases where liquid biopsy or analysis of blood, you're getting the diagnosis, you're getting the preventive modalities, and you're getting the chemosensitivity on blood itself.
Link is not going to US. He will do
slides and
Yeah, so just for the knowledge of what is liquid biopsy, just to introduce the concept. If anyone is getting bored, please do tell me. I will halt it, make it easier for you to understand. I can see some of the backbenchers really looking at it like staring, something is happening. Sorry, that is not the intent. Okay, so you can always come out with your doubts. Don't think it's an oration, I cannot ask. So what is a liquid biopsy? It's very important, please understand. Today, liquid biopsy is a complementary tool. We do a diagnosis by taking out a small bit of tissue. Today, it is possible on blood and it's happening in our country. Please remember that. On a blood sample, I isolate circulating tumor cells. I typify like a pathologist doing an immunohistochemistry, and I say that this is cancer. Can you believe it? It's happening in our country. In the blood, earlier we used to think that the tumor cells will get into the blood only if it's stage 4. Now it's been proven beyond doubt that even early stages, you can see circulating tumor cells in the blood. They only remain dormant and they're circulating in your blood. But once they have all those metastatic niche and all that, once they have the growth factors, they will transform and lead to metastasis. So imagine if you are able to pick up these cases early, then you can prevent disease, and that's what is important about the sorry. So that's circulating tumor cells. So what does liquid biopsy entail? It includes both circulating tumor cells, or commonly called the CTCs, circulating tumor DNA, and let's forget all those fancy names, exosomes and all. These are not happening in our country yet. Now, why is it important to know this? Circulating tumor cells are cells which are shed into the circulation from the tumor proper. And ctDNA, or circulating tumor DNA, is the DNA from the tumor, wherein oncologists try to find out whether there is any expression of whatever, EGFR, all those things, and they institute their therapy based on that. So these two have become now very common in our own country, and people are doing it. So please don't be surprised when they say liquid biopsy, circulating tumor DNA. We understand it's not. We understand it's not there in curriculum, but soon I'm sure in your recent advances you'll have a question on liquid biopsy. So it's important to understand the basic jargon. Eventually, you will understand why it is important. Now, I'll tell you a story. When I was doing my MD, in the recent advances paper, flow cytometry, artificial neural networks were there. I said, what is all this? I don't need to know. I just need to mug up and type my MD. Believe it or not, in 2 years, I got flow cytometry, and I had to remember what all I had studied during my MD exam. That is the way science is moving, and I think sooner, especially the ones who are graduating now, you would have liquid biopsy, wherein pathologists will be expected to report. And please don't think pathology is anymore a sleeping branch. Precision oncology is an example of that. Now, I again won't bore you with what is the protocol now. Invest what they do both tissue biopsy and liquid biopsy together. In our country, obviously, we don't have the resources. We would go for a sequencing on the paraffin block. If it is not working, then they go for liquid biopsy, or vice versa. So it depends on the oncologist. At this point in time, there's no. Why do we have to do liquid biopsy? Because liquid biopsy captures heterogeneity, both in terms of one area having the phenotype, genotype or not, and also the temporal. Temporal meaning at baseline, that is before chemotherapy, it is like this. Later on, it is the genes are reducing. So the disease burden as well. So that is why liquid biopsy has become very popular. And this is what we have done at Dhaka. We kind of isolated, and this has got US FDA breakthrough designation status. We are working on the final approvals. So once this comes in, just imagine if on blood you are able to detect DNA and you do not have to go for these fancy PET CTs and MRIs. If you're getting a simple blood test to detect this, it will be a game changer. Not that we will be out of jobs, our responsibility will increase because the pathologist who has to report these things. I'll tell you my own example. In my center, we have excellent researchers, PhDs, who are doing isolation of circulating tumor cells. But when a pathologist joined, it made sense because they knew the intricacies of immunohistochemistry. So obviously, you know the sensitivity better than a PhD, and therefore it is our role to finally make it clinically relevant in the given setting. So this is the procedure. You might not be interested, but for those of you who have some element of research bent in your mind, in symptomatic individuals, you take sample, a blood sample, and then do something called a negative enrichment. That is to isolate circulating tumor cells, and then I'll just continue if you can. So just like we do our immunohistochemistry, you add the immunocytochemical antibodies to the circulating tumor cells. Look under the fluorescence microscope. Look at, and it's all automated. Now it scans and it gives you the fluorescence intensity. The pathologist only has to say, okay, I'm looking at the TTF1 in lung cancer, makes relevant. That's it. So it's become that easy. Please understand, this is going to scale up. And these are the ones. So in fact, during COVID, when patients were not able to get biopsies, we diagnosed liquid lung cancer, we diagnosed glioma on liquid biopsy, on a blood sample. Though it is not approved, but doctors were referring because they had no other access to patient's tissue. So that is where we are moving now. I again would not, where all it has gone, circulating tumor cell is now important for prognosis, diagnosis. So these are all the publications and ASCO presentations that we have had in the space. So liquid biopsy across the cancer spectrum is available for screening, for diagnosis, for prognostication, for management, and also for monitoring. So without a liquid biopsy, you will not be able to really move ahead. And again, in multidisciplinary tumor boards, it's the pathologist who will be making sense to this report in the to the clinician or oncologist. So that is how we create value in the cancer ecosystem. So now we have moved from tissue to cytopathology, then liquid biopsy. Now we are doing data analysis on this, and also we are looking at the decision making as far as treatment is concerned. We are helping the oncologist. There is smart cytology. People are talking of AI. Again, you have the circulating tumor cell. AI will tell you that this is beyond this fluorescence intensity. So this is malignant, this is not malignant. Again, but then all of these have to be validated by the pathologist. Please don't think that, my work is increased. No. This is again being endorsed by pathologists. So without a pathologist, it won't happen. So this is all how it is moving. Now, eventually, they're talking of radiomics. So pathology, radiology will be working together. We give a comprehensive report wherein they give you a PET-CT report, your morphology, your immunohistochemistry, molecular profiling, and finally tell the doctor that this is my report. And the oncologist takes a call whether to treat the patient with a genetic kind of treatment or the conventional standard of care. So that is the oncologist's call. So that's where we are moving. So pathologist forms an essential part of the multidisciplinary tumor boards today in cancer hospitals. So these are all the areas where as a pathologist you can dream of being. You can be a hematopathologist, you can be a clinical pathologist, you can get into ML, deep learning, AI. This is all pathology informatics. Please understand, if not the techies, you will be into the mainstream now. Clinical research, lab management, liquid biopsy, multi-omics, that is your transcriptomics, then genomics, everything put together. People are getting into biobanking. Pharmaceutical sector is now trying to make biobanks. They need it for the research. And who gives the tissue and the samples? It's again the pathologist. So it's essential that we create value for ourselves. Understand, it's not just reporting your CT or histopathology. You have so much of diverse group. It depends on what you want to pursue in future. So there are some national agenda everywhere for pathologists. And this is the biobank. They call it tissue stewardship, custodianship, a responsibility that involves the charge and control of tissues or samples within specified legal guidelines. Don't think this is not going to be there. Already Tata Memorial already has a biobank, but it's not really reached scale because they want other government hospitals to join. And sooner or later, we'll have these things as well. So pathologists will work alongside AI algorithms to interpret complex data. They will validate the AI generated results. They will mark regions of interest, that is tumor and help in improving diagnostic accuracy. They'll improve the quality and reliability of AI algorithms used in diagnostics. So we will be working alongside AI engineers. Please remember, don't think it is technologists. Don't think it is engineers. We are going to be part of that. So better to understand where your interest is, go for that. We can obviously not look at everything, be experts at everything, but pathology plays a central role in cancer management. So the tools needed are diverse: NGS, digital pathology, artificial intelligence. Drones are being used to transport samples. You can imagine where we are moving. Informatics and lab information. In case you are interested in computers, you are regretting, why did I come to medicine? Still, there is a chance you can do pathology informatics. Point of care testing, and of course, the baseline, which is most important, the morphology. So many of us are excellent at morphology. We can retain that skill and add some more specialty to that. So molecular diagnostics is the fastest growing area of medicine. A significant share can be taken up by pathologists. You have to fight for it. People are trying to grab that. It is me, but the pathologists have the benefit of morphology. So we are at an advantage and we should grab that opportunity. They have the understanding of morphology, IHC, molecular assays, and can generate an integrated report. It is only about taking initiative. Now I express my gratitude humbly to my alma mater, Andhra Medical College, where I began my journey of medicine. Then in Nizam's Institute, which taught me pathology and my teachers. And then I moved to Basotarkam, where whatever knowledge I had gained at Nizam's Institute, I could apply it in the true sense. So you just dream of it and things fall into place. They say that is absolutely true. I'm not saying I have done myself. I had an excellent team at all of these places. And, if we really have that in mind that I would like to go to X place, it will really fall into place once you have a goal and you're working towards it. And this is for the benefit of postgraduates. Please don't think pathology is a sleeping branch. The next place where I went was Datar cancer genetics, which ignited my research interest. Hardcore researchers. I could not believe we are doing something at a That's a reality. I said, no, something is going on. When I went and saw that lab, I was so inspired. I should be participate in something novel is happening. Imagine the first country in the world to get a liquid biopsy, USFDA designation. And they spend dollars and we are spending few thousand rupees. So that is the power of our country because of the beliefs that we have. And I request all the youngsters, please put in whatever effort you are, have a goal, subspecialize in your pathology. And I'm sure you will reach anywhere. Be the change you want to see the world. Remember Mahatma Gandhi. Thank you for patient. Happy to take any question. Don't think it's Oration can't ask question. I enjoy interacting with the students. I really enjoy interacting. You might have silly stupid questions, doesn't matter. Later on also we can. Can I ask? Madam, yeah, sure.
Madam.
I want to share my experience with you, madam. Madam was my first teacher in college.
One of the lecturers had non-Hodgkin's lymphoma. Actually, for 2 years, he was investigated in Bombay. There were small nodules in the lungs. They didn't give much importance. Again, we had another small nodules around the stomach and but they didn't give much importance. But after 2 years, he came, he had some stress, and he developed very large swellings in both ends. And sometimes they advised him to go to a neuro physician. Then I told him, the swellings are a little come to me. We are the people who diagnose. So he came to me, and I have diagnosed with whatever. It is a non-Hodgkin's lymphoma or intermediate cancer. Actually, this is there in the cold food also, intermediate. Then whatever we know, conduct any a biopsy, an IHC, and then they started on treatment. But you know, part of it was theoretical analysis also. So they started one course of chemotherapy. But there is no response. As you know, when the microbes is not much, they won't request so soon for chemotherapy also. It's a slow growing tumor because already says it is 2 years. Then after that, they started, then he contacted Bombay Data Institute. So they advised another biopsy, then another genetic study they did, and another course of chemotherapy was given. But that also didn't show any response. Then finally, there is a hospital, Tata hospital, they have started here now. They took another biopsy and they sent it for IHC, and they finally concluded this mantle cell lymphoma, which will not respond to any chemotherapy, it seems. So how these variations have occurred, instead of spending to such a bigger institute, and now mantle cell therapy also they have given more response. Then final result, they have started on another recent bio chemotherapy. So can it occur with so many variations in the genetics?
So that is where precision oncology really helps, madam, and I'm sure they would have tapped that only. Now they must be ibrutinib or something. So yeah, so that is where precision. So it is tailored to this specific patient that madam is talking about. So the treatment finally would have been based on the genetic profile. Yes. So that has higher chances of success than groping in the dark and giving a standard of care chemotherapy.
Had they done it earlier, probably they would have taken that time also. It was not positive actually for mantle cell lymphoma. So finally they said mantle cell lymphoma may not respond much to chemotherapy. So they started again on, as you told, some biochemical.
Correct.
And in another case, 85 years old man.
Madam, yeah. Madam. I think she'll be able to answer.
I'm a medical probably human heterogeneity must have played a role. So the initial human tissue may not be having the exact histology or the size could not become positive. So finally, I mean, the third sample, exactly the tumor cell is positive for those particular markers have been identified. And mantle cell lymphoma is curable now. We do see even in patients in India also, we have good enough mantle cell lymphoma drugs also available. But there is only one variant called the blaster variant of mantle cell lymphoma, which does not respond to chemotherapy. So probably your patient could be a variant of that. Otherwise, mantle cell lymphoma is local lymphoma is very much response to treatment. That is one. And back to your human heterogeneity, ma'am. I think all of us know the cricketer Yuvraj Singh. He had a gestational tumor. He had a gestational tumor. One biopsy was examined at me. Second biopsy was sent to US. So AE people reported as lymphoma. US report has come as germ tumor. So again, it's because of human heterogeneity. So it only so if people treated it as as lymphoma, giving lymphoma treatment, so it is not that lymphoma did not respond to chemotherapy. So that is wrong. It mainly depends on the pathology. So the pathology is correct, treatment will be according to the report. If the report is wrong, the treatment also will be wrong.
Thank you, ma'am. Yeah, sure.
Congratulations, Dr. Sudha. Excellent and lucid presentation. Congratulations. And we have created not only the PG faculty also. Thank you. All the best. Thank you.
Thank you very much, Dr. Sudha, for that elaborate and lucid oration. I hope all of the postgraduates have understood what their future could be. If you have such a bright future and a very vast scope to grow, please understand it is your basic that you are taking learning here. First two steps, you can run and achieve very high goals, very fantastic and very, you can have a very bright future once you know what is ahead of you and so much of what is there for you to go through. With that, I request Dr. Villa to give you a vote of thanks.
On behalf of Department of Pathology, it's my privilege to propose the vote of thanks on this occasion. Firstly, I would like to express my humble thanks to the sponsor of this oration, Dr. Ravi Sharma Garu and Dr. Seshu Sharma Garu and their family members. Without their constant support and guidance, this event is not possible. We would like to express our gratitude and thanks to our speaker, Dr. Pudipeddi ma'am, for not only sparing the invaluable time for us to grace the occasion, but also enlightening us with a commendable talk on the subject. Thank you, ma'am. We would like to thank the professor for giving his constant support and guidance. We would also like to thank the students for his constant support and guidance. Thank you, sir. We would also like to thank all the faculty members from other departments for graduate participation in this event. I thank you once again for presenting. Thank you.